to talk about the surgical principles in inverted papilloma treatment. David, please.
Ladies and gentlemen, dear colleagues, thank you for this kind invitation, and I'm going to speak about the surgical management on sinonasal inverted papilloma. Within these topics, we are going to discuss some different aspects, the role of HPV infection. Also, we will speak about some diagnostic issue which were very nicely presented by Mario already. Then, before you start surgery, you have to consider some very delicate and important points that I will speak about, and also some few words because I think I can skip that because Mario did that already very well. And in the end, we will speak about I would like to speak about how radical surgery should be done and whether external approaches still have their places. So if you want to get an orientation in the jungle of the literature on surgery for sinonasal inverted papilloma, this is really a difficult task, because you will find some 1,200 items if you just insert the inverted papilloma in surgery. And even if you limit it down to, let's say, some languages, to different trials, you will end up in 90 items that you have to read through. As already stated before, I do not want to go too much in detail because Ernesto Pasquini is really, it's his topic to speak about the malignant transformation, because malignant sinonasal inverted papilloma have to be treated like sinonasal malignancy. However, an interesting topic is always, and keeps on being an ongoing problem, is how frequent we will find sinonasal malignancy in primary benign tumors. If you look at literature, it's estimated between 5 and 11%. We looked in our own series and only found 1 in 102 cases. So when and how often a benign tumor like a sinonasal inverted papilloma turns to a malignancy is unclear. The diagnosis is already mentioned by Mario. I do not want to go in details again because this is just for repetition. However, I would stress some aspects on the computer tomography. The presence of this sclerosis or hyperostotic bone is only found in 60 to 85% according to the literature. And the problem is really how aggressive shall we be in these hyperostotic bone. If you consider, for instance, this gentleman has his hyperostotic bone directly up at the level of the anterior ethmoidal artery. The one below, you have a hyperostosis at the cribriform. Do you dare really to drill all the things down to get these hyperostotic bone removed? I have my doubts, I must say, because the risk of any injury and collateral damages is not that easy to handle. It is an important fact, as has been pointed out by Mario already, that this cerebriform pattern, especially in the T1 contrast enhanced images, is quite important to see. Let's say it's an important fact that shows the type of tumor is quite specific for inverted papilloma, but there are many that do not show these cerebriform aspects. To me, in our experience, the magnetic resonance imaging is especially worthwhile for the extension into the frontal sinus. I will speak later on this topic. Now, on office-based biopsy, this was the question from the floor. What do you do with the biopsy? If you see, for instance, this is an entire tumor that could be removed, and only this part here was in the nasal vestibule. So you have to take the biopsy far back here, or in the lower specimen you see this is the aspect in the nostril, this is the one in the sphenoid, but these are only polyps if you take the biopsy. So you have to go far back to take a biopsy. So to us, the value of the office-based biopsy is really questionable. As well, questionable is a frequently discussed topic on the Krause classification. Recently, there was an interesting publication by Lisan and colleagues in 2017, and they made a meta-analysis on 30 studies with over 1,700 patients, and they could only find the following correlation. If you have a T3 stage, then you can say the risk of recurrence is fairly high. But there was no difference between 2.1 and 2T2 stage. So is that really worthwhile to use and to adopt this Krause classification? I have my doubts in this circumstance. Now, the risk for recurrence in surgery is also very well established. I just summarized the literature in these, and this is also our experience. Incomplete resection is not really a recurrence, it's a persistence of tumor. Frontal sinus involvement, of course, this is a difficult task to remove the tumor out of the frontal recess into the frontal sinus. The presence of dysplasia is associated with a high recurrence rate, multifocal attachment, so if we have several attachments of the tumors, and also pertinent in HPV infection, but this is a topic that I would speak later on. Frontal sinus involvement. We found 19 out of 102 cases that had a frontal sinus involvement, but none of them were really attached in the frontal sinus. Okay, we can say this is a series, this is not a very big series, and it's only from our center. In the literature, this is a very difficult task to find out whether someone did a study on the frontal sinus involvement and what he really means with it. Is it really originating in the frontal sinus, growing down to the ethmoid, or the other way around? Frontal sinus involvement, I skipped that. I just repeat one more time what was excellently presented by Mario, is the two T2 weight images that show the fluid in hyper-intense, whereas the tumor is hypo-intense, and the other way around in the T1 weighted images with contrast, where the tumor is hyper-intense and the fluid is hypo-intense. We started to do some studies on HPV infections in benign sinonasal inverted papillomas, and we found out that there is not any correlation with that, except for a special HPV, and this is the HPV 11. But the benign tumors can be, let's say, HPV can play an important role in the presence of dysplasia and in the multifocal disease. HPV 11 is a completely different pair of shoes, we would say, because I just show you one example. This was a lady, a nurse, that had an inverted papilloma in the left nasal cavity. He was operated elegantly. Post-operative scans were absolutely normal, no involvement in the frontal sinus. But 6 months later, there was a recurrence. And if we looked on the opposite side, this is between the superior turbinate and the septum on the right side, there was also inverted papilloma. And if we had a look into the nose to the nasopharynx, then we found that it is on the posterior wall of the soft palate. There were also papillomas. But if we took some samples from there, then it showed also inverted papilloma, but it was HPV 11 positive. This is a completely different pair of shoes. This is an infectious disease. Now, what are the surgical goals? Of course, we want to remove the entire tumor, and as it is a benign tumor, in the majority of cases, then we have to think twice how aggressive we should be. I just would mention one more time this hyperostotic bone. If it is attached to a very delicate structure like the skull base or so, you have to think twice to remove it really radically. Now, the easiest case is this one. Involvement of the inverted papilloma in the anterior ethmoid and the maxillary sinus. You do a partial anterior ethmoidectomy, that means uncinectomy. You open the anterior ethmoid layer cells. Eventually you have to open the maxillary sinus depending how deep the inverted papilloma is running into the maxillary sinus, is bulging into the maxillary sinus. As soon as the sphenoid sinus and the skull base is involved, you need to open the sphenoid. That means you do a sphenoethmoidectomy. So in addition to the partial anterior ethmoidectomy, you do a sphenoidotomy. You have to identify the sphenoid plane because this is the most constant landmark of the skull base. And then you come anteriorly to remove cell by cell the tumors out of these ethmoid layer cells along the skull base. As I mentioned already, the T2 images and the contrast-enhanced T1 images are essential to define whether there is an involvement into the frontal sinus. And then you have to do the partial anterior ethmoidectomy. You take the 45-degree telescope, you open up the frontal recess area, and then you start to open the frontal sinus like it is shown here. And this is by definition to us a frontoethmoidectomy. That means you have identified the frontal sinus. You had a look into the frontal sinus. Then you can combine it with a T2, with a draft 2 or with a draft 3 procedure, with a drill-out procedure, as has been outlined in other publications. So in summary, we would say one thing in sinonasal inverted papilloma that you have to face is it a benign or a malignant tumor? If it is a malignant tumor, this is completely something different, and I'm very glad that Ernesto Pasquini is with us, and he will explain how to deal with that. The size and the location of the tumor determines the extent of surgery. So you remove as much as is really necessary. Inverted papilloma from the frontal sinus itself seems to be very rare. We didn't see anyone, but according to Mario's data, we must say it's around 3%. If you look at all these publications on surgical management of inverted papilloma, we today would say the potential that we have to use traditional external approaches is below 1%. Thank you for your attention.
Thank you very much. You're so right while you're saying the recurrence, if you in the first surgery don't really remove everything, then it's a persistence. And in the case of frontal sinus region, I mean, I have encountered patients who had inverted papilloma in the frontal sinus, and they have been, some of them were operated before, so I cannot really distinguish if it was originally attaching there or if through the recurrence it's, also went over there through the scar tissue, I don't know. But the thing that I want to ask is that if you would have inverted papilloma originating from the frontal sinus, what would be your approach? Because, I mean, just an external approach, or would you go further endoscopically, or then if you go externally, would you obliterate? You know, there are a lot of questions.
That's a good question. I think the vast majority of these, I would always try to give a chance the endoscopic approach, always, because you never can predict where it is really attached. Of course, in this very interesting case that has been showed by Mario, I think there you can estimate that it is in the midline, it is the posterior wall of this frontal sinus. These are potentially the criteria that will allow you to go for that. However, if you imagine that eventually it won't be possible to remove the entire tumor out of the frontal sinus, I think this potential is very low, that you cannot really approach every single part of the tumor. But then to skip to an external approach causes a lot of morbidity to the patient, and that's the advantage of the endoscopic approach that we actually have. I think I would always give a chance to the endoscopic approach in any case, except for, of course, of the malignant, but this is a completely different pair of shoes. The other question on the obliteration is the following. We were all trained, as soon as you do the external approach, no matter whether you do the Weber-Ferguson approach or coronal approach, then you obliterate the frontal sinus. But I have to say it is very difficult to follow these patients with the MRI scan, because the fibrosis of the fat tissue that you put in to distinguish that from tumor, especially from benign tumor, is not that easy. So what we did, if we have a good drainage into the ethmoid, we started not to obliterate the sinus anymore, but to keep it open, like a median drainage from superiorly. And for instance, in malignant tumor, this is a very elegant technique. However, if you have a very narrow space in the frontal recess area, then you have to think twice whether you can just keep it open.
Thank you very much. So, also, although it's not a part of the frontal sinus, the supraorbital recess being a part of the ethmoid pneumatization area, that sometimes makes problem. But with Mario would think with the orbital transposition or periorbital suspension, by pushing the orbit a little bit laterally, you can really reach that area. And in our hands, we also try to leave it controllable with air functional. Mario, would you like to comment on that?
Yeah, I would like just to add a small comment about that, because usually we start in all cases endoscopically with endoscopic endonasal approach, because as David told us, in large majority of cases you can manage the inverted papilloma in a radical way, complete excision by endoscopic endonasal approach, even when the tumor involves the supraorbital recess. We drill out the supromedial bony angle of the orbit, and we perform the so-called orbital transposition. We push laterally the orbit in order to reach the supraorbital recess, and we were also able with curved drill to drill out all the bone of the supraorbital recess. But we start with endoscopic endonasal approach because basically in all cases is necessary, because even for external approach, even when we understand that it's not possible to perform complete excision through an endoscopic endonasal approach, but even when we perform an external approach, in all cases we rehabilitate the ventilation of the frontal sinus. Never obliterate the sinus, never. And so, also when we perform coronal approach and external through osteoplastic flap, in all cases we perform draft type 3. In this way, frontal sinus always ventilated, connected with the nose, never obliteration, and this helps a lot for the follow-up and also helps patients, because if you obliterate the frontal sinus with fat or so on, you can have high risk of infection, and also patient complains headache. So never obliteration, always rehabilitation of the ventilation, restore ventilation of the sinus, even in external approach.
The major issue to me is, if you speak with a neuroradiologist and all the colleagues, it is a difficult task to distinguish tiny recurrences, for instance, in this fibrotic fat.
Yeah.
Because during these, if you follow the fat obliteration over 10 years, you see even changes after 5 years, that it becomes more fibrotic, and then it makes it really difficult what is recurrence and what is just fat.
Well, thank you very much. So it's also my practice as Mario told. Any other questions? Yes, Tomislav, please.
I think the Italian group from Piero Nicolai, they pointed out that it is absolutely mandatory to think twice how much should be removed. We started to do the, let's say in the 90s, to do endoscopic endonasal medial maxillectomy. And endonasal medial maxillectomy implies that you remove the middle turbinate and the inferior turbinate. Today, we must say, why that? Because it is a benign tumor. We are speaking about a benign tumor. So why to remove the turbinate? Yeah, I mean, okay. Let's say, if we take a sinonasal inverted papilloma and we approach this tumor on the background that we were confronted with a benign tumor, and then the pathologist comes and tells us it is a malignant tumor, then Ernesto Pasquini will tell you, you have to be much more aggressive. And then to cut the turbinates, yes or no, this is depends on the extension of the tumor. A second step. Eventually, I mean, we were confronted with a biopsy that was not reliable. We had something benign, and then the definite histopathologic workup and molecular pathology showed that it is a malignant tumor. Then you have to go back because it is not correctly treated.
Okay, thank you very much, Professor Holzman. David, thank you.